I'd now like to introduce myself. Kia ora koutou, ko Anna Gilmour takuinga. I've been a GP in Dunedin for the last 17 years. I completed my postgraduate certificate in allergic diseases from the University of Western Sydney, which was a great course for doctors, which I completed 3 years ago. I've been running an allergy clinic in Dunedin since then, and I've just started clinics in Invercargill as well. I've got a nurse working with me, wonderful Kathy, who has completed her postgraduate diploma in allergy for nurses, which is through the University of South Australia, and that was a fabulous course as well. So we're very lucky to have her knowledge and skills in my clinic. We see children and adults with allergic asthma, hay fever, eczema, food allergy and chronic urticaria. And I'm also a member of the Allergy and Eczema Clinical Reference Groups and the Paediatric Society Allergy Special Interest Group. So my job is to talk about food allergy in adults. Well, I think you remember this slide from before probably, or a similar version that Annalise put up. And I'm going to basically use this to talk about three sort of cases that I think demonstrate some of the food allergy things that are different in adults compared to children. So there's a lot of similarities, but I'll try and highlight some of the differences. So just to recap, IgE-mediated disorders are kind of the easy allergy, if you like, and non-IgE-mediated, and we'll come back to the IgE-mediated, but non-IgE-mediated things like FPIEs, proctocolitis and enteropathy, I think Annalise has spoken to, and then there's mixed disorders like the eosinophilic disorders, eosinophilic esophagitis, which is really quite rare and not something I'm going to talk about tonight, but is fascinating all the same. And tonight I've got a few cases that are going to demonstrate some of the IgE-mediated things. So, right, so case one. This is a 60-year-old New Zealand man who presents, he's had multiple incidents of food-related reactions over his adult life and a couple as a child as well. He, as a result of these experiences, mostly avoids fish and seafood. The first, many of the symptoms that he experiences are quite mild, but the first sort of major thing he remembers was, as a child, having blue cod soup, which is just blasphemous and a waste of blue cod. But he remembered having that and being taken to hospital and doesn't remember a lot more about it because he was quite small. But since then, his family would avoid, if they went for fish and chips, his family would avoid giving him the fish and they'd get him a hot dog instead. He still remembers, though, that sometimes he'd have a hot dog and be able to sense a tingling in his mouth, and he knew when the hot dog was cooked with fish and things like that. So he remembers that. He also remembers or knows of times where he's had meals with fish flakes and fish sauce in, and sometimes got mild symptoms of sort of tingling in his mouth and things. So generally his symptoms would be at the time of ingestion or very soon after. He'd often get things like swelling of the lips, swelling in the mouth, throat, sometimes breathing problems and wheezing and lightheadedness and sometimes even vomiting. He had about 2 months prior to seeing me in clinic, he had a taste of three pieces of salmon sushi. And within 10 to 20 minutes he was flushed, he was short of breath, he had throat swelling, dizziness, nausea. Now, most people would think that's a good time to call an ambulance, really, it is. And I impressed that upon him. But at the time, he lives rurally. He was a bit terrified and not thinking very rationally, as is often the case with people experiencing anaphylaxis. And so he just sat really quietly, and fortunately the symptoms abated over about an hour or so. The biggest problem for this guy is that his wife is Japanese. Now, she loves seafood, and sushi and raw fish and all of these things. So it really is a bit of an issue. He also lives rurally, as I said earlier, so a little bit sort of exposed and worried about what that means in case he has a reaction and his wife refuses to give up the seafood. His other history, he has mild seasonal allergic rhinitis, and he's very well otherwise. He's on no regular medications or anything. So this sort of takes us away from allergy a wee bit, but it's fascinating all the same. The question is, what could have happened to this guy at the salmon episode? I mean, there's all this other background as well, but could it be a toxin? Or is it an allergy? So let's talk about toxin first. I know that's not allergy, but as I say, it's still interesting. So in other words, is it a poisoning? So if we think about the likely possibilities here, chiguatera is a toxin which, if you ingest it about 3 to 5 hours after you've had it, you'll develop symptoms and usually vomiting and diarrhea and feeling dreadful. It's not uncommon with barracuda in particular and other ocean fish, and clearly that's not the case with this guy. His reaction was a lot sooner than 3 to 5 hours. So the other thing to think about is scombroid poisoning, and this is something that happens typically quite quickly. The reason it happens quickly is because it actually resembles anaphylaxis, and the reason is that it's basically a whopping load of histamine. So you'll remember that Annalise talked about histamine being one of the mediators that's released from mast cells and causes one of the mediators that's related to causing all the effects that anaphylaxis presents as. So if you get a whopping load of histamine without all the bit in between that comes from allergy, then potentially you get the same appearance or the same symptoms at the end of the day. So with this toxin, it's also known as histamine food poisoning or fish poisoning. It's commonly with fish like tuna and mackerel. Kawai in New Zealand is known to be a problem. And it's the kind of thing that the longer the fish has been killed for, the more toxin there is. And that's because it creates the bacteria in the fish gut produces the enzyme that breaks histidine into histamine, and that then is the overload. The trouble with it is that by cooking the fish or freezing the fish doesn't sort the histamine. It sorts the bacteria, but by that time the enzyme's released, and so you've still got histamine production, and the histamine's still there. So it's pretty nasty, and it can look exactly like fish allergy. And it can also occur in salmon and sardines, even though they're not scombroid type fish, typically speaking. So could it have been that in this guy's case? Well, maybe, but the same sort of reactions happened before. So, and also he's never tolerated he's never tolerated any fish that he knows of without a reaction. So you'd expect if it was scombroid that the fresher the fish and all different varieties and shellfish as well, that you probably wouldn't get it with those. So on to the topic of tonight. Could it be allergy? Could it be the salmon that's the problem? Is he just allergic to salmon? Well, no, we know he's had a reaction to blue cod, but we also know with fish that there's a lot of cross-reactivity. So it's not unusual to be allergic to all white fish or most white fish or all fin fish, or and there's quite a lot of cross-reactivity. So then the other question is, could it be Anisakis? Now, when I was choosing my middle name recently, I couldn't decide whether to make it Sarkis or Phylaxis. So I'll be interested in a poll at the end of the night. But Anisakis has got some ring about it. So and Anisakis is a mostly freshwater parasite, lives in freshwater fish. And it's possible to have either infestation from this. It's a worm, so you can either have the infestation and be quite sick with that, with GI symptoms and things. Not very common. It's usually from eating raw fish, or you can have an IgE-mediated allergy to this particular parasite. So that in that case, because it's IgE-mediated, it will look similar and present in the same way as someone who has a fish allergy, a true IgE-mediated fish allergy. So how do we test for this? Again, Annalise spoke about skin prick testing and serum-specific IgE. And really, when it comes to fish, we've got pretty useless allergens So if you're going to buy allergens in a bottle to do skin prick testing with for foods, often it's better to actually use the food. So in my clinic, I ask people to bring the fish or whatever it is, the culprit that we're testing, and we prick the specimen and we prick the person. So you really want to make sure you've got a clean specimen of something. So to begin with, this guy, before he came to see me, had actually already had the serum-specific IgE testing, which was negative for cod, salmon, tuna, shrimp, mussel, and anisakis, which I'd requested the anisakis. That one hadn't come before. But we decided that because the allergens were a bit useless for testing, that we'd do skin prick testing. So I asked them to bring in a literal smorgasbord of food, and what the deal was that what he was allergic to I could take home, what he wasn't he was allowed to have. But fortunately he was allergic to most of it. So, well, he was sensitised, I should say. So he was positive. We got positive skin prick tests for squid, mussel, teriyaki, moki, leather jacket, prawn, clam, blue cod, sole, tuatua, and they forgot to bring salmon, which was interesting. But actually, a negative skin prick test wouldn't have changed my advice to him to not have salmon, because he'd had a pretty clear event with the salmon. And he was negative for crab and oyster. So his wife was delighted that they'd be able to go away and cook up some crab and oyster in multiple fashions and see how that went. So I haven't heard from him since, so hopefully that's gone well. And probably costing them a lot of money, I suspect. So I think we're all what you call fish experts now. Does anybody know the term for fish expert? No, good guess though. Pesca something was the guess. Anyone? Tom? No? Fisherman? No. Ichthyologist. I just learnt that today, so yeah. That's obviously where the skin ichthyosis comes from, yeah. So, yeah, there you go. Fascinating stuff. So this case does demonstrate some of the differences. You know, fish is not, in my experience anyway, and I don't know if Tom and Annalise will be able to comment on this, I don't see many kids with fish allergy, and particularly shellfish allergy. When I did my clinical training in Australia, lots of kids would have tasted shellfish at least. Here, hardly any have tasted, and a lot of adults haven't tasted shellfish either. So, or they state that they haven't. So it's interesting how just across the Tasman there's different sort of tastes and things. But fish allergy certainly does seem to be one that can come on at any time of life, and typically in adulthood. Plus, it's complicated because there's all these other toxins and anisakis, IgE-mediated allergy, and things to think about too. The other things that this case brings to mind that's different about adults compared to children would be that obviously adults don't always have supervision, neither do some children, but little children, infants and very young children have always got somebody with them, right? You hope. So for the most part, if an adult is on their own and tasting something out and about or while they're travelling or something like that, it is quite important that someone knows what could be going on for them if they have a reaction. So things like medic alert bracelets and things are important to consider, I think. The other thing, of course, is age-related comorbidities that make a big difference to the impact of a physiological response like anaphylaxis. So, for example, ischemic heart disease, congestive heart failure, asthma, COPD, chronic kidney disease, any of these sorts of things, and some of the medications used to manage them can make the situation a lot more dangerous. Medications, as I said, ACE inhibitors and beta blockers can make the management of anaphylaxis a lot more difficult should it occur. And so people who have a food allergy to something that is difficult to avoid, or they're travelling to areas where the food is very prevalent and it may be difficult to avoid for that reason, then if there's an alternative to an ACE inhibitor or a beta blocker to treat what it is they're on the medication for, then it's always worth considering. Non-steroidal anti-inflammatories, I mean, they have a direct prostaglandin effect, and prostaglandin is one of the mediators, can have an impact on the degree of reaction that you have, and also how likely a reaction is to occur with varying amount of allergen exposure. Alcohol has an impact. Tend not to talk to the kids about alcohol unless they're sort of over 13, but the little ones, obviously it's not an issue for them. Alcohol is a direct histamine liberator and has its effect as a cofactor as well, so worth knowing. Menstruation, again, it's not something for kids to need to worry about, but for women, menstruating age, around menstruation is a time where potentially, again, this can be a cofactor, in other words, something that can make the risk of anaphylaxis greater, the reaction also greater. And all of these things combine to give you a greater risk of fatal outcome with anaphylaxis. So one of the take-home points I always remember about when being taught about children and anaphylaxis is the younger the child, the more rare it is to have anaphylaxis and the more vanishingly rare it is to die from anaphylaxis. So parents are always quite encouraged by that when I tell them that their 8-month-old has an egg allergy. But it's something that you know, as you get older, your capacity to deal with a response like overwhelming anaphylaxis becomes less ideal. So Annalise already brought up the picture of the anaphylaxis action plan. This is the one that you would give somebody who you're giving an EpiPen or suggesting an EpiPen for. And the important bit, and Annalise did this too, we're like one of a kind, her and I think, is this bit here about things to look out for. So I usually say to people, even if we haven't discovered exactly what it is they're allergic to, I usually say this is the important thing, you're much safer now than you were before. A, you've got an EpiPen, and B, you know what are the signs to look out for. So it's really important that if you are seeing somebody who's had a story of anaphylaxis or you think may be at risk of anaphylaxis, then you're giving them an action plan that they can carry with them and use or produce for others to use in their, in their presence. Okay, so I'll move on to the second case, which is a 65-year-old man. He had, before seeing me, he'd had 3 to 4 episodes in the last year of hives. And on 2 occasions, they had occurred when he had been eating out about 3/4 of an hour to an hour and a half earlier, and then he had been walking home when the hives came on. A further episode, though, these were sort of milder episodes, but the subsequent one, which prompted his presentation to my clinic, was he'd eaten about 1.5 hours. He'd had pizza and beer. The pizza had had apricot sauce on it and chicken. And about 1.5 hours after eating, he'd gone for a walk on the beach. He developed hives while he was walking on the beach, and he started to feel generally unwell and got lightheadedness and then collapsed. Fortunately, he was with his wife, and she hadn't given him seafood. No, just joking. And he was taken to ED and observed overnight, but didn't require any medication. So things just kind of gradually settled. So you naturally try and put together all these episodes and figure out what's in common with them. On some occasions that he'd had the hives, and on this occasion where he'd had the collapse, he'd had a beer or 2 with his meal. On two of the occasions he'd had pizza. On all 4 occasions, actually, he'd had something apricot related, and on most occasions he'd been walking when he'd first noticed the symptoms, which was the first symptoms were always hives. He's a man who takes Inabase Plus and amlodipine for his blood pressure, and he's otherwise pretty well. So, what could the diagnosis be? I guess his natural reaction was, well, it's apricots, and it absolutely could have been apricots. It's not impossible to have an IgE-mediated reaction to any protein in food, and although it's not a common one, it's a possibility. So we sort of worked on that premise, while in the back of my mind I was thinking this sounds more like an exercise-induced anaphylaxis related to food. which is a little bit kind of less common, but I was dead keen to find one, so I was going to pursue that anyway. So, and to test for wheat-dependent exercise-induced anaphylaxis, or WEDIA, you can test the antibody, the IgE antibody for omega-5 gliadin, which is a wheat protein. And in his case, I wanted to do this because I thought it'd be great if I could find one. And sure enough, it was positive, moderately positive, which doesn't prove, as Annalise says, positive sensitization does not prove allergy. But it was a little thing, a little string that I thought I'll hang on to that. And I raised this possibility with him. He was absolutely mortified that it could be wheat related because he loves his beer and pizza, and so he was going to cling to the apricots for now. So we suggested that he stop having apricots altogether, which he did, and we were going to, because this was in spring and there were no apricots in the shops, and we didn't really want to use tinned ones because we weren't sure how accurate that would be. We decided that we'd test him in summer with a fresh apricot if he hadn't had a reaction. If that was positive and he'd avoided them and not had a reaction, then that was probably what we were dealing with. But he avoided them and he still got some reactions. Mild, but hives. And he knew at the time that he got the reaction he was to stop doing what he was doing, which was always walking usually, and to take an antihistamine and just rest up. So we made an assumption at that point that it likely was this wheat-dependent exercise-induced anaphylaxis, and told him to avoid wheat, and most importantly told him please to see a dietitian. And I speak of the front row here. They're not rugby players, for those of you who can't see the audience. They are dietitians, and they're an amazing resource. Which I have a friendly dietitian in Dunedin, who I refer a lot of my clients to, and really important. So not just about how to avoid the food or how to replace nutrients if you are avoiding a food, but how to make life interesting if you're going to have to take beer and pizza out of your diet. So for him that was important. So how could this be tested? Well, we talked about the omega-5 gliadin antibody, and talked about excluding the culprit for the large part. He was going to sort of see if he could, just have a little bit here and there, and I explained to him that it's a really difficult thing to anticipate. You can't say on this day if you have this much of the wheat, then you'll be fine, and because every day is different, and there are these cofactors that play a part in how quickly and how much of a reaction you'll have. So what can be done to keep him safe? Obviously an anaphylaxis action plan, an EpiPen and a medic alert bracelet were all things that I suggested to him. So I guess this is just another plug for the cofactors for anaphylaxis, aside from the dose of allergen. Things that can augment the size or likelihood of a reaction include non-steroidal anti-inflammatories, exercise, alcohol, hormonal factors, heat, and infection. So things like upper respiratory tract infection can contribute to a more significant response as well. Okay. So that brings me to the third case, which is a 33-year-old female. She presents with 4 to 5 years of oral symptoms of tingling, itching and burning inside her mouth, and she gets that immediately upon eating things like plums and cherries. But she's also noticed it when she's had pine nuts and walnuts. So she knows she can eat plum jam, no problems at all, and glazed cherries, easy, no symptoms with either of those things. And so for this reason she believes that she's probably allergic to a chemical or a pesticide or something like that that's used in the growing or processing of these fruits. And this is a really common story that I hear, and people usually don't come to me with this story for this reason. They're coming for another reason in relation to allergy, and usually it's hay fever. So but they mention this, or when I ask, is there anything that gives you a reaction in your mouth, they go, yeah, peaches, it's the furriness of them. And they've got a reason they've put it down to. But almost always, if the fruit or vegetable is responsible, in this case, it will be not a problem if it's cooked or treated. So does anybody know what this what this diagnosis is? Well done, yeah. So the key thing there as well is that she has asthma and hay fever since childhood, and her symptoms are worse in spring and when visiting Central Otago. I'll come back to that. So we got a very clever GP in the room who said oral allergy syndrome, also known as pollen food syndrome. And it's very common. It's typically in the patients I see in the lower half of the South Island, it's related to birch pollen allergy. And the reason why this person's worse with her hay fever in spring in Central Otago is that's where springtime is where birch pollen's flowering, and Central Otago and Christchurch actually are very high in birch pollen trees or birch trees. So there's cross-reactivity between the birch pollen itself and the protein in some fruits and vegetables and nuts. And so the body's a little bit confused about the protein that it's seeing, and it mounts a bit of a response, mild response usually, inside the mouth to the protein in the food that's similar to the one that they're allergic to in hay fever. So it's quite a satisfying one to be able to tell people about. Oh yes, that's our oral allergy syndrome. Almost always not associated with anaphylaxis, so you can usually reassure people. But by that time they've figured out they don't really want to get those symptoms, so they just don't have that food in that form. Apple's a really common one, particularly with birch cross-reactivity as well. And so a lot of people go, well, I can eat the apple as long as I peel it, or if it's cooked, it's absolutely fine. And so for most people that will be the case. And then there's grass and weed pollen crossover as well. I'll just show you. This is just a few of the examples. So if you have birch pollens at the top, if you have a birch pollen hay fever, allergic rhinitis, then you won't have oral allergy syndrome to all of those, or potentially any of those, but you may do. And sometimes the cross-reactivity is actually a bit more skewed than that, so I don't find it quite as easy to go, right, it's honeydew, so it must be a ragweed. It doesn't really work like that, I don't think, in my experience anyway. So are there any tests that can help us with the diagnosis? Yes, you can do skin prick testing, and skin prick testing for birch will tell us about birch pollen sensitisation, which often is associated with allergic rhinitis, seasonal allergic rhinitis. And you can also do skin prick testing for the fruit. So it is IgE mediated, this reaction. If you prick what is she allergic to? Plum, and then you prick her skin, you probably will get a positive wheal, indicating that skin IgE response that you'd expect also in the mouth. Some people have, by the time you talk to them, they may have had very little in the way of hay fever, or they've stopped getting their hay fever at all, and yet they still get the oral symptoms. So it's a little bit unusual like that. And typically, but not always, the reaction to the food will be worse in the season where the pollen is highest as well. So it's an interesting one. So the management of pollen food syndrome is, you can use antihistamines. Sometimes if you take an antihistamine before you eat whatever the food is, your symptoms will be very mild, if any at all. Cook or sometimes peel the food. So if it's apples, sometimes peeled people will be okay, but certainly cooked they will. Nuts tends not to make a big difference. The protein is very similar cooked or not, is my understanding, whereas fruits and vegetables it can make a big difference. And there's some early thoughts that subcutaneous or oral immunotherapy may actually be helpful for oral allergy syndrome, although it's not kind of the key indication for using it. And probably oral immunotherapy for aeroallergens for allergic rhinitis could be a little bit dodgy with oral allergy syndrome, so I'd be sticking to subcutaneous if I was going down that route. So I think I'm ahead of time. What time am I? Yeah. Great. So just to finish off though, because I thought we might be running out of time by now, just to finish off, there's some common myths which have been touched on by others tonight, and I just want to make sure that they're good take-home messages for everybody really. Allergy tests, and Annalise plugged this point as well, allergy tests will determine someone has an allergy. That's a myth. Obviously an allergy test may tell you about sensitisation. Equally, it's possible to have false negatives. So a negative test does not mean you don't have an allergy, and a positive test does not mean you do have an allergy. Another myth, you cannot have an allergic reaction to food the first time you taste it. We know that's not true. We know that especially with children, they can be sensitised through the skin, is the theory, and so the first time they taste a food is not an uncommon time to react. So we know that's a myth. You cannot have an allergic reaction to a food you've previously tolerated. That's a myth as well. It's not unusual for people, adults in particular, to present with food allergy for something that they have eaten for years and not had a problem with. Why? I don't know, but probably someone clever does. Another common myth, allergic reactions get worse with each exposure. People often come in and they say that, and they say, oh, every time I have it, I'm getting something worse happening. That's a myth as well. So it's very dependent on all these cofactors that I talked about earlier as well. And the other myth that I suppose I believed as a medical student was if you gave someone antihistamines or steroids soon enough in their reaction, then they wouldn't have anaphylaxis. And clearly that's not true either. The only treatment for anaphylaxis is adrenaline. Antihistamines and steroids may improve comfort, but they're not going to prevent anaphylaxis from happening. So, any questions?
We do have a question from outside. Any thoughts on using vitamin D and vitamin C in treatments, presumably for adult allergies?
Yeah. So the question was, is there any thoughts around using, you already said it into the microphone, around vitamin D and vitamin C. Vitamin D, I think there is some work, particularly in Annalise and Tom will be better at answering this probably than me, but there is some work that's looked at, particularly with, I think, Gideon Lack, looking at vitamin D supplementation, and potentially a lack of vitamin D is one of the things that may contribute to food allergy in children. In adults, I don't know if there's any research around that. I think probably vitamin D is one of those things that can do very little harm, and most of us are fairly deficient anyway. So I think if you've got someone who you think may be deficient for one reason or another, giving a supplements probably once a month is probably not going to do a lot of harm if they're otherwise well and don't have parathyroid problems. And vitamin C, I don't know what the evidence is around that. Neither of them are things that I say that people should take and use to prevent allergy or to treat allergy.
Annalise would chime in then. It's fair to say we see phenomenal amounts of vitamin D deficiency. So this is not really with my allergy hat on, but vitamin D deficiency is incredibly common here in the South Island, mostly in people with darker complexions, but actually across the board. Does supplementing it reduce your rates of eczema or allergy? I've not seen any evidence that it does, but just like some of the other things we've said this afternoon, there's nothing wrong with topping up your vitamin D. Another one coming through has just said, does food allergy have any ethnic preference or ethnic variation?
That's a good question. And it seems that there is a higher prevalence of food allergy. And again, Annalise and Tom are more expert in this field probably than me, but certainly from my learning that there is a higher prevalence of food allergy in Western cultures and in urban populations as opposed to rural. So that relates or may relate to the hygiene hypothesis, where dirt is good. Very hard to sell that one in COVID times.
I'll chime in a little bit here. I agree totally with what Anna was saying. And by the way, Anna, I really like your polar for your middle name there.
You should do one too.
Yeah, I should do one too. The other thing which talks a little bit to the ethnic background and maybe also to the whole genetic and epigenetic phenomenon that actually goes alongside with the hygiene hypothesis, that what we're exposed to in our environments, potentially also what we're exposed to in utero, can change how we kind of methylate and switch our gene expression on and off. And we know there's been a lot of work done on that, and that kids are sort of get out there and sort of play in the dirt and rural, potentially, have less eczema and food allergies. The other interesting thing that came out of some Australian studies was that children born to, so second generation, for example, Asian children, have exceedingly higher rates of eczema and allergy than their parents who were born in Asian countries. And that really probably speaks also to the difference in what's actually happening at a sort of genetic and epigenetic level, different diet, different environmental type exposures. Which is really interesting, and whether we're actually seeing that in some other ethnic groups, as well. There is also some evidence, and I was going to chime in before a little bit as well, very limited, but it is there, and it kind of goes along with, can we do anything potentially modify, the risks of eczema and food allergy? And there is, as I said, some that taking probiotics and diet high in omegas in the third trimester of pregnancy may help to reduce risks of eczema in subsequent children. That's something I often tell families about as well. Just as a little bit I forgot to mention.
Thanks, Annalise. Any other questions? You need the microphone.
When it comes to infants and like things like baby massage, a lot of different oils are used. For example, like apricot kernel oil. What would be the safest oil to use in like a 3-month-old baby age group?
Baby oil? I don't know. Tom, you might be better to answer that question.
So I'd go for the baby oils. The Johnson's baby oil is the one that everyone uses.
I don't think they're made from baby, so I don't think there's any risk of baby allergy.
Yeah.
I think as long as, if it's a kiddo who's got, beautiful skin and no evidence of eczema, it's probably okay. But I agree with Tom, straight up oils, baby oils, because, baby massage is nice and it's important and it's great, but, bonding and development and, I'm sure it has other benefits. So, yeah, finding a safe alternative would be a good recommendation.
There was one last question from outside was comments about gut microbiome and allergies. It'd probably be a good one for you, Annalise. And we've touched on it a little bit, but any last thoughts about the role of the gut microbiome in all of this?
Yeah, sure. I think my viewpoint, and this is how I often look, I probably have this discussion multiple times per week with my patients, because obviously there's, gut microbiome is a hot topic across the board, particularly in immunology and in the field of allergy. And I kind of say, look, we are only just starting. We're really a drop in the ocean in terms of how much we actually understand about the gut microbiome. If you think about it, where is your largest proportion of immune cells? Well, it's in your gut, isn't it? Which is kind of really interesting. And we don't potentially understand it yet. What we do know, and it is very interesting, is that the gut microbiome in children with eczema and in children with food allergy is different. So studies that have had a look at, the type of flora and the diversity of flora in those populations is different than the non-allergic. Now, what I kind of say, and that may, as I said, speak to what I was just saying before, and that there is a recommendation that maybe probiotics in the third trimester of pregnancy may help, because once you've, the horse is bolted and you've already got food allergy and eczema, what we don't know is how much does changing it by use of probiotics actually help to modify, the disease progression. I kind of say, well, look, I don't think it's probably going to do any harm, but it may not necessarily do anything significant. And as Tom really talked about as well, I think studies are ongoing with that. Again, like in the oral immunotherapy field, there one group, particularly out of Melbourne, is looking at using probiotics, to help with that as well, because they think it may play a role. So overall, I say to families, look, we don't fully understand it. I don't think they're harmful. If the horse is bolted and you've already got their eczema or allergy, I'm not sure how much it will do, but if it's not a bad thing, I don't have a problem with it.
Got time for one last question? Well, one last question was just touching on what you were saying then about oral immunotherapy. The question is there any desensitization available? And the simple answer is no, outside of scientific trials. Everyone's looking into it, peanut especially, but all of the studies so far, participants still are at risk of reacting, and there's no evidence to show lasting tolerance. And so as long as you're in the study, there may be some benefit for some children, but as soon as you stop, you're just at risk again. So it's of no great value. Don't know if you've got any thoughts on
I
that.
agree. The big meta-analysis is a little bit that the jury is still out. And I often say, well, ask me again in 2 years and we'll see where we're kind of up to. It is being done across the board, predominantly in a research field and also clinically in North America, a lot in Japan, as well as in Europe. And the data is really just starting to come out about that, because what we don't know yet is what is the best way to do it. For example, is it oral immunotherapy? Is it PET, sort of epicutaneous type immunotherapy? What is the best way of doing it? What is the best foods to use? How much do we use? And as Tom just alluded to there, what is the safety profile? Because a big meta-analysis came out that we are still seeing reactions in that. And in the centre I worked in, I mean, it was amazing sitting with patients who had anaphylaxis to peanut, eating peanuts in front of you. That was quite something. But it's not here yet. I think it will come, but it's not yet ready for prime time. It has to be in a safe, way before we start, putting patients at risk.
Okay, thanks Annalise. And Mark, I'll hand over to you to wrap up.